To Aetcm, the emergency medicine channel. Today we are going to have a case discussion on rheumatological case come to emergency room, further admitted to internal medicine department. We have Dr. MGK Pillai sir, he is head of medicine, and Dr. Karthika. Can we start?
Yes, sir.
Please start.
44-year-old female from Kakinad. She is a LIC employee. She is the informant, reliable source of information. She came with complaints of bilateral lower limb swelling since 1 week, pain in the right lower limb since 1 week, and worsening of dyspnea since 2 days. History of presenting complaint. The patient was apparently asymptomatic 1 week back when she developed bilateral lower limb swelling and pain in the right lower limb. The swelling was subacute in onset, initially localized to the bilateral angle joint, later progressed up to the knee. The swelling increased after standing for a while and keeping the leg in hanging posture. It subsided with lower limb elevation. She also developed a dragging type of pain over the shin of the right lower limb along with the swelling. The pain was acute in onset and progressively increased, which affected her walking. There was no aggravating or relieving factors for the pain. She also gave a history of trauma to her right lower limb 2 weeks back, following which she developed an ulcer over the right sole. She also had worsening of dyspnea from NYHE class 2 to 3, which was her baseline, to NYHE class 4. There was associated orthopnea present. There was no history of fever, chest pain, palpitations, cough, reduced urine output, jaundice, urticaria, no history of prolonged travel or recent surgery. Coming to the past history, she is a non-case of type 2 diabetes since 11 years, systemic hypertension since 10 years. She was diagnosed to have rheumatoid arthritis since 7 years and with associated ILD since interstitial lung disease since 2 years, and she is on domiciliary BiPAP and 4-liter O2 support. No history of surgeries in the past. Personal history, she complains of reduced sleep, normal appetite, mixed diet, normal bowel and bladder habits, and she has a normal menstrual cycle, 28 cycle, day cycle with normal flow, and she is not habituated to alcohol or tobacco. Coming to family history, no history of cardiac disease or rheumatoid arthritis in the family. Drug history, she gives a history of steroid treatment for her rheumatoid arthritis. There is no history of recent travel or prolonged travel.
Can you summarize the history?
Yes, sir. A 44-year-old female with a background history of type 2 diabetes mellitus, systemic hypertension, rheumatoid arthritis with interstitial lung disease, presented with complaints of bilateral lower limb swelling, preceded a trauma to her right lower limb and also pain in the right lower limb, and worsening of her on baseline dyspnea to a more NYHE class 4 dyspnea.
So, what would be your provisional diagnosis?
So, sir, with the history of trauma to the lower limb, with the pain in the lower limb and edema, I would like to consider infection / inflammation to the right lower limb, and also with the background history of rheumatoid arthritis, interstitial lung disease, and also worsening of dyspnea, I would like to consider either it can be a worsening of interstitial lung disease or it can be a cardiac disease with cardiac involvement due to the bilateral pedal edema with dyspnea.
Can you focus on the right lower limb here?
Yes, sir.
Can you tell the difference in diagnosis?
Right lower limb can be a deep vein thrombosis,
yes, correct.
or can be a cellulitis, or can be
simple arthritis?
Yes, sir. Arthritis flare.
So, what about if the presentation is with the DVT? What complication can lead to dyspnea?
Pulmonary embolism, sir.
What kind of dyspnea it will be?
Acute onset dyspnea.
What are the other causes of acute onset dyspnea?
Can be acute pneumothorax or acute onset of acute massive pleural effusion,
Diffusion will take some time.
Yes, sir. Okay.
What about infections?
Yes, sir. Infections.
Can be rather acute.
Yes.
So in your case, you are not suspecting any embolism?
No, sir.
No.
Why you are not suspecting pulmonary embolism?
Because the patient already has a dyspnea, but it happens in 2 days. Along with that, there is no history of prolonged travel or surgery to suspect in terms of
The
an
problem
embolism.
is when we are getting a case like this, we are only thinking about acute pulmonary embolism.
Okay.
There is an entity called as chronic pulmonary embolism.
Yes, sir.
Patient will be developing chronically embolism to the lungs. They can progressively become breathless. Suddenly one day they come to the emergency department or hospital. You have to keep it in mind.
Okay,
There is a possibility of chronic pulmonary embolism in rheumatological diseases. But here we are not able to make a proper diagnosis of pulmonary embolism because he has not presented acute dyspnea. There is a progressive dyspnea. So you have to keep it in mind.
Okay, sir.
Anything else to be asked there?
Yeah, any other change can happen in the lung with what Dr. Gireesh was telling you about chronic.
Pulmonary artery hypertension due to
chronic thromboembolic pulmonary hypertension.
Yes, sir.
That also will lead to progression of the dyspnea to the next class.
Yes, sir.
Good.
You are telling about ILD.
Yes, sir.
What is the possibility of ILD in a case of rheumatologic disease like rheumatoid arthritis? What are the possibilities?
Is it common
correct.
or is it rare?
It is not rare, sir.
It is not rare, but it is not very common also. But what are the causes for ILD in a case of rheumatoid arthritis? Cause is secondary. You can always tell it is a secondary to
cause.
rheumatoid arthritis. But one more thing is that this patient may be on methotrexate.
Yes, sir.
That can induce pulmonary
Drug
fibrosis.
induced.
So you have to keep it in mind. One is the disease-induced pulmonary ILD. Another one is drug-induced. Both are possible.
Yes, sir.
From a point of view of medicine PG, this is possible.
Yes, sir.
Okay.
All the possibility you have to consider. The discussion goes like that.
Okay.
What is the importance of family history in rheumatoid arthritis?
Rheumatoid patient in family, there is a more genetic predisposition for rheumatoid arthritis. If the patient is having a family history, patients who are having a rheumatoid arthritis, they have a background of a MHA, MHC, HLA gene mutation.
Okay. Any
What
sex difference?
Yeah. What is the importance of asking male or female like that or looking into
Females are more prone for getting rheumatoid arthritis.
any ratio approximately?
2 to 3 is
3:1 usually, more for females.
Yes, sir.
What about the habits?
Smoking can cause rheumatoid arthritis.
Can cause means
Predisposed.
it's a very important risk factor on
Yes, sir.
rheumatoid arthritis.
Okay.
Right.
So we can go ahead to the examination.
Sure.
Yes, sir. On examination, general examination, patient is moderately built and nourished, weight is 59 kg and height is 157 centimeter with a BMI of 23.9. She is conscious, cooperative and oriented to time, place, person. Physical examination, she has pallor, bilateral pitting pedal edema extending till the knee. She also has grade 3 clubbing, no cyanosis, icterus or lymphadenopathy. Vital signs, pulse rate 108 per minute, normal rhythm, volume, condition of vessel wall and no radiofemoral delay. All peripheral pulses were palpable. BP 130/80 mmHg, respiratory rate 28 per minute, saturation 95% in 1.5 liters of O2. And she is...
Can I ask one question here? This
Yes.
what finding you got, positive finding is pallor.
pallor, sir.
This patient has got anemia.
Yes, sir.
What are the causes for anemia in a case of rheumatoid arthritis?
Anemia of chronic disease.
Correct. That is the most important thing. You should never miss. That is, any chronic illness can produce bone marrow suppression. That can produce anemia.
Yes, sir.
Okay. Other causes, anything you know?
Methotrexate induced.
Okay. Bone marrow suppression due to the drugs. That is also very important. Okay.
Yes, sir.
Again, they can have GI bleed because they are taking lot of NSAIDs.
Yes.
Lot of other things are there. But bone marrow suppression can be there. Methotrexate induced bone marrow suppression can be there. Hemolytic anemia can be there. So all these things
Nutritional
anemia is there.
And you are also mentioning about the peripheral pulse.
Yes, sir.
Is it important in rheumatoid arthritis?
Yes, sir. The patient will have a arthritis.
Yeah, that's also well known,
Yes.
rheumatoid arthritis.
Yes, sir. Head to foot examination. No scaling in the scalp. No conjunctival congestion or dryness of the eye. Oral cavity, no ulcers.
When you tell oral cavity, you tell about temporomandibular joint.
Yes, sir.
One of the most important joint which can be involved in conditions like rheumatoid arthritis. Simple high cholesterol itself can produce severe pain in the temporomandibular joints. So temporomandibular joint is the important part of examination
In RA.
skeletal system examination. Okay.
And what about eye involvement in RA?
Scleritis, rheumatoid arthritis, there will be scleritis, episcleritis.
Yeah, so this dryness of the eyes is a well-known symptom in rheumatoid arthritis. That is secondary Sjogren's.
Sjogren's.
It's an important thing.
Yes.
Okay.
No rashes, no pitting of nails, no onycholysis, no subcutaneous nodules, no palmar erythema.
When you told about rash, one of the most common presentation of this type of disease is acute onset of rash, high degree fever, high ferritin. What is that condition?
Lupus.
Adult onset Still's
Still's
disease.
disease.
That is one of the common presentation in emergency room.
Okay.
They have high fever. During the fever time they have rashes. Then they have history of joint diseases in the past.
Okay.
So one of the differential diagnoses, adult onset Still's disease. Their ferritin levels also very high. That is very important. Okay.
Okay, sir.
And you are mentioning about polyarthralgia,
Yes, sir.
or multiple joint involvement.
Yes, sir.
So already your patient is labeled as rheumatoid arthritis.
Yes, sir.
Can you bring few other situations where you can get small joint and large joint involvement?
Yes, sir. Psoriatic arthritis,
Good.
osteoarthritis.
Osteoarthritis
more
pattern may
likely-
not be
yes, sir.
like that. Okay,
Yes, sir.
little more.
Seronegative spondyloarthritis.
Okay. What about viral fever?
Yes, sir. Epstein-Barr virus.
Yeah, there are some
parvoviruses.
viruses that can present with small joint.
Most of
Then
the
what
viral
is, yeah,
diseases.
this is very important. What about a similar disease with a multi-system involvement, systemic autoimmune disease like RA?
Lupus.
Yeah,
SLE.
SLE. Here actually
Only difference-
synovial involvement is less in SLE.
Only difference
Compared
may be
to
it's a deforming arthritis, other one is non-deforming.
Non-deforming.
But arthritis is same.
Yes, sir.
Same.
And psoriatic arthritis you told,
Yes,
one
sir.
of the differential diagnoses, psoriasis mainly involves distal interphalangeal joint. Rheumatoid arthritis mainly involves the
Proximal
proximal
in-
interphalangeal. It's a major difference.
Yes.
But otherwise, most of the time it may mimic same type of disease.
Okay, sir.
And two rare situations also can be there. Examples. Similar pattern can be there. Chronic sarcoidosis.
Okay.
There can be multiple joint pain and other thing.
Okay, sir.
Okay.
Can continue. Cardiovascular system examination. So, sir, as the patient is having bilateral pedal edema and dyspnea, first I would like to examine the cardiovascular system.
Before going to cardiovascular system examination, what are the differential diagnoses there in your mind? Then only you look for that.
Yes, sir.
In rheumatoid arthritis, what are the possibilities you will get in heart?
There can be pulmonary because the
Pulmonary
patient,
hypertension.
patient is having underlying ILD, can be a pulmonary artery
Okay,
hypertension, following which she can go into a right heart failure.
Okay, right heart failure. TR can be there.
Yes, sir.
Okay. Then other one is pericardial effusion, aortic regurgitation, AR.
Yes, sir.
So these are the common findings. They can have conduction blocks, pericardial effusion, pericarditis, TR, and AR.
Yes.
AR is very very common in conditions like this.
Okay.
So you have to look for that.
Yes, sir.
But I am telling you, if you are not thinking about that, you will never look for
May
that.
not.
Sir, JVP was raised by 4 centimeter. Inspection of the precordium. Shape of the precordium was normal. Apex beat was visible in the 5th left intercostal space 1 centimeter medial to the midclavicular line. There was a visible pulsation in the 2nd intercostal space, and position of the trachea appears to be central. Palpation. Apex beat was palpable in the 5th left intercostal space 1 centimeter medial to the midclavicular line and confined to the 1 intercostal space. Palpable pulsations present in the left 2nd intercostal space with the pulp of finger. No thrill present or dilated veins. Percussion, right heart border was corresponding to the right fourth intercostal space and left was corresponding to the left fifth intercostal space. There was a mild dullness present in the second intercostal space. Auscultation, mitral area, S1, S2 heart normal, no clicks or murmurs. Coming to tricuspid area, there was a pansystolic murmur of grade 3 present in the tricuspid area.
I just wanted to ask you, you have no murmur in the mitral area.
I didn't.
You have a murmur in the tricuspid area.
Yes, sir.
How do you know that it is originating from the tricuspid valve? It's very simple. Ask the patient to take a deep inspiration. All right-sided murmurs will increase on the deep inspiration. Or you raise the leg. So all right-sided murmurs will be increasing on the right side. It's called as de Carvalho sign.
Yes, sir.
So that is a very important clinical tool.
Yeah.
Here we don't know whether the murmur is actually originating from the right side or left
Very
side.
difficult.
It's a very close area. But you are telling it's the right side. Then you have to ask for deep inspiration, take another auscultation, and if it increases, it is on the right side. It decreases on the left side.
Okay, sir. Coming to pulmonary area, loud P2, no murmurs present in the pulmonary area. Aortic area, S1,
Loud
S2.
P2 indicates
Pulmonary artery hypertension.
hypertension. Okay.
Aortic area, S1, S2 heart normal, no murmurs present in the aortic area, sir.
So
Coming,
here from the heart you get a lesion like pulmonary hypertension with
sir.
tricuspid regurgitation.
yes, sir.
Okay.
And respiratory system examination, upper respiratory tract, no deviated nasal septum, no sinus tenderness, no nasal polyp, oral cavity, no tonsillar enlargement, no postnasal drip, external ear, pinna was normal. Inspection, shape of the chest bilaterally symmetrical, trachea appears central, there is no drooping of shoulder, there is hollowness present in the supraclavicular and infraclavicular area bilaterally. Apical impulse was visible in the fifth left intercostal space. Movement of the chest was equal on bilateral. Skin over the chest, there was no scars, sinus, encouraged veins present. Sir. Palpation, no local rise in temperature. Position of the trachea was central. Apex beat palpable in the fifth left intercostal space, 1 centimeter medial to the midclavicular line. Movement of the chest was symmetrical. Vocal fremitus symmetrical in all 8 areas bilaterally. Chest expansion was 6 centimeters. So. Percussion, so there is a mild dull note present in the bilateral infrascapular and infraaxillary area.
You can say impaired.
Impaired. Sir. Drop space was resonant. Auscultation, normal vesicular breath sounds heard in the all 8 areas. And vocal fremitus was also symmetrical in all 8 areas. Fine inspiratory crackles were present in bilateral, infraaxillary and infrascapular areas.
So in interstitial lung disease,
Yes, sir.
what type of crackles you expect?
Velcro.
Velcro.
Yes, sir.
Maybe a little early or maybe a mild disease.
Yes, sir.
So here by this time you got 2 diagnoses.
Yes.
Possible ILD. ILD is already proven. TR with pulmonary
Hypertension. Coming to locomotor system examination, joint examination, there is no swelling, warmth or tenderness present.
Is there any name given that pattern of examination? What is GALS?
Gait, attitude and
Arms,
arms and legs.
legs, spine, leg.
Yes, sir.
It's given most of the test box.
So when the patient come to your clinic, you have to look at the gait. That is
Yes,
the
sir.
first thing.
Yes, sir.
Then head to toe examinations, whatever are told, everything will come.
Everything will
So you don't miss anything. That is the advantage. So gait is very, very important. What gait you will get in most of the rheumatological diseases? Suppose you have a hip joint pain.
Antalgic gait, sir.
Like waddling, like on both sides you go. Because there is a joint pain, one side, it will be limbing type of pain. Okay, it's different from neurological gait, but orthopedic gait or rheumatological gait is slightly different.
Yes.
But we have to look at the patient,
Yes.
what type, so whether pain is there, look at the face, because of pain he is unable to walk, everything should be told.
Sir, she has upper limb hand deformities,
Okay.
swan neck deformities there, sir.
Okay.
Range of motion, all the joints, including wrist joint, metacarpophalangeal joints, all small joints and large joints were normal, sir.
You checked both active and passive movements?
Yes, sir. Hip
So
joint.
she has got proximal interphalangeal joint involvement.
Yes, sir.
Okay. Bilateral, symmetrical, proximal joint involvement directly goes in favor of a rheumatoid arthritis.
Then other system examine, neurological system, she has a reduced vibration sense.
Okay.
Otherwise,
What are the neurological problems she can have?
she can have a peripheral neuropathy, sir.
Okay, peripheral neuropathy is very common.
And she can have cervical rheumatoid arthritis is rarely involved with cervical
myelopathy.
These things are rare, but
Yeah.
common things are, one is carpal tunnel syndrome,
Carpal
very
tunnel syndrome.
common, everyone will get. Every rheumatoid arthritis patient.
That comes under with which category? Carpal tunnel syndrome?
entrapment neuropathy, sir.
Yeah, that is very important. Very, very important.
Then, like you told, peripheral neuropathy is there, sensory neuropathy, motor neuropathy. Myelopathy is not very common. Like you told, cervical myelopathy can be there, but not very common.
Okay.
Lumbar and lower part, it is very rare. It is not at all common, but cervical can be there. Okay.
That rheumatology examination you completed, spine.
Spine, yes, sir. Spine was, there is no tenderness.
Yeah,
sir.
in that area you have to
No.
tell specifically about movements of the
Neck.
cervical.
So you have to do all the range of movements.
Movement.
Extension, flexion, all these movements we have to do.
Okay. Summarizing the case, sir.
Okay.
44-year-old female, non-case of type 2 diabetes mellitus, systemic hypertension, rheumatoid arthritis with the ILD, presented with the complaints of lower limb swelling, pain, worsening of dyspnea. Physical examination revealed a tachycardia, tachypnea, and she was also found to have pallor with grade 3 clumping and bilateral pitting pedal edema. Cardiovascular system examination revealed elevated JVP with a palpable P2 and loud P2 with the pansystolic murmur in the tricuspid area, and she was also found to have bilateral base crepitations in the infrascapular and infraxillary.
So when this patient comes to emergency room, what you should take care? We'll go to the detailed
yes, sir.
treatment after this. She
First-
comes to emergency room. She has got breathlessness, fluid overload state, tachycardia, all these things. How do you take care in emergency room?
Airway, breathing, circulation.
So
First,
what airway problem she is having? She is not having any airway problem. Everything is settled. She has got some circulation problem. That is fluid overloaded
Yes.
condition maybe because of anemia,
yes, sir.
or because of TR she is having fluid overload. How do you relieve the fluid overload in this patient?
IV diuretics can be.
Diuretics are most.
Yes.
So this patient may require some oxygen BiPAP ventilation. Then diuretics will help the patient. If needed, blood transfusion.
Okay, sir.
You can go to investigation you are done or treatment part.
Yes,
What
sir.
other cardiology problems can happen for this patient?
Right heart failure.
Heart failure already told. Then
Yes, sir.
anything else? What about the incidence of coronary artery heart disease and rheumatoid arthritis?
They are.
Yeah,
Yeah.
much higher.
Yes, sir.
And already you mentioned about involvement of the aortic valve.
Yeah.
So valvular heart disease can happen to them. Involvement of pericardium, pericardial heart disease can happen. Right.
Yes.
Can you tell what is Merantis endocarditis?
It is a subacute bacterial.
It is
sorry,
not
it is non-infective
non-inflammatory endocarditis
endocarditis.
seen mainly in RA, SLE and all. It's not infective.
Yeah.
So that also possible. Okay.
Yes, sir. First, we'll investigate send the routine investigations, including complete blood count,
Okay.
elevator, ESR, and
If the
CRP,
neutrophil count is low, what do you call it as in rheumatoid arthritis?
Felty syndrome,
Okay.
What other findings?
Splenomegaly,
splenomegaly, neutropenia, and rheumatoid arthritis.
In lymphadenopathy also is.
Okay, sir. Then I'll check for the, as the patient has a diabetic, check for the RFT also to see whether there's any worsening. Also see for other causes of pedal edema, including hypoalbuminemia, so LFT can be done. Also maybe she is taking any immunosuppressant, so LFT.
Steroids.
Yeah, also other methotrexate like that, if LFT is also required. Then urine routine to see for any proteinuria
Okay.
for the patient.
Okay. Can this patient develop amyloidosis?
Yes, sir.
Okay, that is also possible.
Yes.
Nephrotic syndrome due to the disease itself is possible. She can very well develop amyloidosis.
Yes, sir.
Pulmonary involvement, you told already there is interstitial lung disease.
Yes, sir.
What other pulmonary involvement can be there?
Pleural effusion can be there.
Pleural diseases are well common, it's well known, very good.
Then.
What about vasculature?
Yes, sir. Vasculitis.
It's known.
Yeah.
And even the tubes can be affected.
Yes.
Conduction airway also can be affected.
Yes. Then I would like to see a chest X-ray to look for any pleural effusion or ILD.
Okay.
Yeah. Then coming to the management.
On ECG we can take,
yes, sir.
because conduction abnormalities can be there.
Yes, sir. Then coming to the management, acute emergency management is we have to look for airway.
Do you want to still do rheumatoid factor in this patient?
Yes, actually we can actually look for the flare of the disease by checking the anti-CCP levels.
But rheumatoid factor may not be helpful because already it will be elevated.
Yes, sir.
So it may not help. Anti-CCP sometimes can be done to prognosticate the disease.
Yes,
but
sir.
most of the time physicians will avoid these investigations because already it is done. We know that clinically it is increasing and it may not be required.
Okay, sir.
But prognostically you can tell if the factors are remaining very high, the activity of the disease is also prognostically very bad.
Yeah.
In that way you can.
Okay, sir.
Because the same patient can have some other disease like infection can flare up the symptoms. So anti-CCP may be helpful.
Then I would like management basically by now this patient as she has a fluid overload stage, we have to consider a active diuresis and also oxygen support plus for the
anemia is there, we have to correct anemia. That is very important because even if we remove the fluid, few days after she will develop fluid overload state. The anemia should be corrected. Is there any role for erythropoietin here?
Patient is, there is not much renal, if there is a much renal involvement only we can consider.
One of the strongest indication for erythropoietin is renal failure.
Yes, sir.
But erythropoietin can also be used in patients who is anemia of chronic illness, anemia due to HIV. Okay. So many conditions this can be usable, but not like renal failure. But it is indicated. We can give a trial.
Okay, sir. Then I would like to treat if there is any flare or anything, we have to consider the management of rheumatoid arthritis flare. But this patient doesn't look like she has a flare of rheumatoid arthritis.
What drug she is on?
She's on right now. She's on prednisolone only, so Vicelone only, and she was taking leflunomide, but we discontinued because the patient is having a infection. Also, we are not right now.
Why not she? Why she is not on methotrexate?
She had, yeah.
Is there any reason?
Yes, sir.
Is it because of the present problem it was discontinued or
previously
discontinued?
Most of the time what happens is when the patient is on methotrexate and when the patient develops ILD like features, many physicians actually stop the drug because they think that that may be due to methotrexate. That may be the reason, I don't know. But there are alternatives. Steroids are not a very good choice when the patient is already having so many fluid overload. You can acutely give, but you have to switch to some other drugs which can spare the steroids.
Yes, and then
so general management you are telling about.
Yes, sir.
So what about the pathogenesis and then selection of drugs?
Actually newer generations are coming, newer generation drugs for the rheumatoid arthritis. Yes, sir.
So inflammation is the most important pathogenesis feature here.
Yes,
so
sir.
what way you will control the inflammation?
We have, there are numerous cytokines involved in the development of rheumatoid arthritis like tumor necrotic factor, interleukins 1 and 6. All this we have now, interferon alpha, all that we have now agents for all the, to control this thing like biological DMARDs. Okay. So in that case we can actually.
So first you will give NSAIDs,
yes, sir.
Looking at the renal parameters.
Yes, sir.
Then you will introduce which one?
Ideally we have to introduce DMARDs.
So which are all the commonly used DMARDs?
Methotrexate, leflunomide, sulfasalazine, azathioprine.
Any chloroquine derivative?
It's hydroxychloroquines. Yes.
When you give hydroxychloroquine, what will you ask the patient?
Ophthalmological evaluation.
Any rotation in the eyes?
They
And
have
also,
to put sun tan
yeah,
sun
screens
that's also.
and ophthalmological examination like what you told. Methotrexate.
We have to ask this patient to check regularly for CBC to look for
Okay.
any neutropenias.
What vitamin you give along with methotrexate?
Vitamin B12
Folic acid.
or folic acid.
One of the
Folic acid.
most dangerous problem of methotrexate induced bone marrow suppression, they come to emergency room with neutropenia. How do you manage that condition?
Leucovorins we can give.
Folinic acid. That
Folic
is
acid.
an active form of folic acid. That should be given.
Yeah.
And stop the methotrexate.
Okay.
What is the next group of drugs?
Biological DMARTs. You can have infliximab, rituximab, all that
Okay.
group.
Rituximab.
Yes, sir.
Very well. What about tocilizumab?
Tocilizumab is also.
Yeah, it's also coming up.
Yes,
No.
JAK2.
Which are all the drugs available depends on. So if it is available there, they can select.
Yes, sir.
Most of the drugs were, the trials were over and it's proven that it is beneficial.
Yeah.
But you have to individualize the treatment and decide.
Yes, sir.
How do you treat the pulmonary hypertension here?
Bosentan we can.
Bosentan, before Bosentan. Bosentan is a drug which can be used in primary pulmonary hypertension. Sometimes it may be helpful here. What other things you can give? In pulmonary hypertension, there are different conditions you get pulmonary hypertension.
Yes, sir.
What is the simplest way of treating pulmonary hypertension? It is oxygen.
Okay.
Continuously giving oxygen in lower dose, that reduces the endothelial proliferation in the pulmonary arteries, reduces the pulmonary hypertension. It may not completely cure the disease, but it improves the quality of life.
Okay.
Then what you told, Bosentan is a drug which tried in primary pulmonary hypertension, but it can be tried here also. We don't know whether it will fully work like type 1.
Okay, sir.
Then
Anything else to be done for this?
steroids.
Steroids, yes. Right now the patient is having a fluid overload. We can actually continue.
Otherwise,
Otherwise we can
you have
start
to
on a
give.
lot of steroids. Sir.
Early stages, it is very useful.
Yes, sir.
But always you should have the control. Otherwise, patient may continue using steroids because that is one of the best acting or best anti-inflammatory. So they will continue. They may not visit you
Okay.
once they enjoy the effect of steroid. You should warn and give.
Okay.
Never give high dose.
Okay, sir.
If suddenly they stop the steroid and come to hospital, what are the clinical features they can have? Sudden stoppage of steroids. This is applicable for doctors also. Suddenly we may
Long
stop.
term use, then suddenly stopping.
Hypothalamic hypopituitary.
What is the clinical
Suppression.
finding?
HPA.
Yeah.
This is hypotension.
Yes, sir.
Refractory hypotension, then you have to give steroids. Like you give in sepsis. Refractory hypotension, you have to give steroids.
Steroids.
Okay. Any side effects of steroids?
Patients will have fluid overload, hypertension, which can lead to hypertension,
Hypertension, diabetes, obesity,
yeah.
skin diseases, infection,
Bone.
osteoporosis.
osteoporosis. How many things are? This patient can he have hip pain due to some reason?
Yes, sir. Vascular necrosis.
Vascular necrosis. That is very, very important. Anything else, sir?
Yeah, but you did mention about that pathogenesis of that. What is happening inside the joint?
Basically, what happens is there is a antigen presenting cells which has a MHC receptor and also the toll-like receptor. These will go and bind to the T lymphocytes, and this will CD4 plus T lymphocyte, and it will get differentiated to helper T cells and effector T cells. And this helper T cells, it will actually stimulate the B lymphocytes, and this B lymphocyte will maturate to form a plasma cells, and it will result in the formation of antibodies. And also this effector cells is actually increases the osteoclastogenesis. So this can cause the it will increases the osteoclast precursor, it will stimulate, and it increases the osteoclast.
So what is the pathological finding in the joint?
Pannus
formation. So what is the radiological finding in a rheumatoid arthritis joint?
Osteopenic it will be.
One is osteopenia. Second, what will happen to the joint? Gap. There's
it will
an-
decrease in the gap.
Yeah, narrowing.
Narrowing.
Then what will happen to the
Sclera-
soft tissue?
Inflammation of the
Swelling.
swelling.
Yeah, so
Yes,
soft
sir.
tissue swelling, joint space narrowing, periarticular osteopenia. Then what can happen little later?
Sclerosis.
Now what will happen at the end of the bone?
Osteophytes will be there.
Osteophytes.
Okay, sir. Thank you, Karthi. Thank you,
Yes,
sir,
sir.
for your guidance.
Thank you.